Okay, all right, here we go. Don't show this again. So hopefully, let's see if I can do the thing where I bring other people over. Okay, so attendees. Hopefully I can promote here. All right, David, good. Okay, are you guys getting this? Crawford, are you able to? Yep, looks like I'm able to do the thing where I bring people over, so that's good. Good, hopefully. And then, okay, David, we'll see if we try to there. Sorry if I have to do this for so long. Okay.
Medical at Lee Community Healthcare, 13279 North Cleveland Avenue. Respond on dispatch 2. Medicaid 32.
Huh, sorry about this. Looks like there's a lot of people I got to bring over, so be patient with me. Jim, in the meantime, why don't you plug in the CME? I think on the invite it said 21416. You can double check me. I think that's what it is. I'd appreciate you putting that into the chat as I'm doing this duty here, bringing everybody over. Okay. There we go.
I'll take care of it.
Okay, thank you so much. Was that the right number, by the way? Is that what I said? It's probably right there on the invite that I resent this morning. So
yeah.
Or does anybody else have access to that? And let me know. Okay.
It's 21416.
Yeah. Okay. Good. That's what I thought. All right. Think we're almost there, at least for now. Okay. So, and maybe later when I'm talking, I'm actually going to be doing one of the talks today. So, which is really cool. Okay. It's small group today. A lot of people are out. Glenn's doing his thing with his, mom. I think Glenn said, "Oh, Glenn, are you there? Wow. Where were you? I thought you weren't going to make it. I thought you were out at the Western White House." Glenn Seda, are you there? Because I had gotten a note from him saying that he wasn't going to be able to make it. So
35. You are clear from standby.
Well, maybe not. Okay.
Sorry, Glenn's here. I'm sorry, I couldn't find the damn button.
Yeah, I know. Yeah, classic, right? Classic Casada. Couldn't. If I heard that excuse every time, I'd be a millionaire by now, right? Hey, Glenn. So where are you? Are you out on the West Coast? Or are you in San Francisco? Or what?
No,
Huh?
I'm back in New York, and with our UN stuff.
Oh yeah. Oh yeah. Yeah.
Yep.
How's that going, by the way? What are any snafus or anything that you've seen so far that are problems or the usual? Huh?
They're not good. Luckily, there's some small conferences that are still going to go on, but we were lucky. Netanyahu spoke this morning, so we're all holding our breath too. But everything so far went very well.
Oh, good. I'm glad to hear that for you. But you guys are old hands at it. But disasters are disasters because you can't predict them. That kind of thing. So it's just something else.
Yep.
All right. So let's move on and see. I'm trying to see if Eileen or John Jew are on by any chance. Hopefully Eileen is on. Nope, I don't see her. And John, are you there? Yep, you are. Hey, John, I was just going to have you guys mention these things. Are you interested in the superbug thing that I had talked about by any chance? And tell us a little bit about it.
Yeah, I'm not really ready to present that, Paul.
That's fine. Then don't do that. But the one thing you probably do know about is the other thing I saw. I'm in New Orleans and thinking about having some oysters here are the big thing here, and I'm thinking not really, because there's already been I think there's about 8 or 9 deaths in Louisiana recently from
it's like
from Vibrio, I bet, right? Isn't it that? What's
yeah.
What's that?
You were talking about volnificus, huh?
Yeah. Well, actually, I'm one of those ID guys that never eat raw oysters. It's like there's no way. That's honestly, from an ID point of view, that's pretty damn stupid.
Oh yeah, because it's filter. It's it's like pick your favorite disease, hepatitis, norovirus, what have you. I mean, that's why I always tell my students I like my parasites cooked.
Yeah,
that's correct.
That's right. I love it. Yeah, I don't know. I actually don't like the texture that much myself, so that's something else, that kind of thing. All right, but but the thing is that why are we seeing a whole bunch of deaths? Is it global warming issue and they're more warm? Because I think we're seeing it in the Gulf Coast, all over the Gulf Coast, I think. And what if now someone asked me last night, what if the oysters are shipped in from Maryland or something like that, right? Okay, we got the answer to that. Thank you very much. And how about they come from Lee County? Jim Augustine's there. He's looking after everything, right? So, which is funny. But, we all became really acquainted with Vibrio because that's something we talk about when you do have, a hurricane or whatever else, and then your workers are out there and they get cut out there and they start getting an infection. You better be thinking about that if there's salt water involved, et cetera, as your possible infectious agent, the Vibrio. Okay. Any other comments you could make on that? You're just saying, just don't eat them. Okay, got it. But Eileen, is it from more global warming and we're seeing more cases, or are we seeing more cases?
We are seeing more cases every year as the oceans warm up, and there's more concentration of Vibrio, which is a natural bacterium in water anyway. So Vibrio vulnificus concentrations go up, and therefore the infectious dose gets into people more easily and into oysters more easily. So yeah, you can do it by consumption. Yes, you can get it from wounds, and you're absolutely right. You've got to be very, very on top of it and think of it right away, because the treatment is different than for other wound infections, and it's got to be done fast because it's a killer.
Yeah, and I think that's important for EMS folks who are out there, maybe in a like a Joe Holly and so on, who's out there, on site, and you have to treat. Yeah, we'll get you some, whatever, antibiotic du jour, and so on, and then do. And Joe, so for example, what is that something you've been in that positions from time to time, and the same thing with Jim Augustine, right? And so you have a heads up on that already, correct?
Yes.
And rescue 61.
Sorry, go ahead, Jim.
Yeah, just we have a continuous education about that for all of our rescuers and into the hospitals. Every time people come in with wound infections that have been in the water, we have a big issue. Every year they publish a couple cases in the local media about people who've had significant losses because of it.
Yeah.
And then what are the medication recommendations that you have at this point in time? Like if it's a extremity wound of some sort?
Usually a mix of antibiotics. You don't usually use just one. So you can use doxycycline and Fortaz as one choice, right? There are also some third generation cephalosporins that'll work, but you can't use your basic penicillins or that sort of thing. You've got to go with the big guns, and usually, like I said, more than one antibiotic. If you don't lose lives, you can lose limbs too. I mean, that's another horrible thing about this. Yeah.
Yeah. So, because they call it flesh-eating bacteria. That's classic. Oh, I'm bringing it up just because it is still, we've got hurricane season, and there are some threats to the East Coast right now. And so I just wanted to get a nice, timely reminder as well. Keegan, you quietly had your hand up. Go ahead.
Yeah, it was
David Baramontes, you're live. Just so you know, David, you're live. Okay, go ahead. Go ahead, Keegan.
So it was just funny because it was reminding me when you said, your workers are going to be out there. When I deployed down to the Bahamas after a hurricane, it's amazing what they'll get into. We had a chicken coop on one of the islands that we went out to, and the guy had left it, but I guess he tried to freeze all his chickens to save them. Maybe he was hoping he was coming back, so there was a big giant block of ice with chickens in it, dead chickens. And I found out a day later that I had to tell some of my deployed medics that they're not supposed to be using that ice for their drinks from the chicken ice. So It's amazing the kind of diseases you'll run into. And it's funny we were bringing that up about post-hurricane stuff.
Well, we do have our world's expert on it here to tell you what happens post-disaster. So Eileen, let me back up.
I'd be curious what she thinks preferred antibiotic coverage for chicken ice is.
Oh.
First, your advice was best. Don't drink it. Don't eat it. Don't consume it.
And no ice, right? That's right.
Yeah.
Okay.
No. What were you going to ask me, Paul?
Oh no, I just wanted to answer his question. About don't drink it, but what is the treatment? What are the symptomatology and what is the illnesses that they get, Keegan, that you experienced?
Well, I mean, it's not going to be typhus because it's not it's not usually Salmonella enterica typhus. It's going to be a different Salmonella, and so you can treat it with standard, beta-lactam antibiotics.
Yeah, it becomes real fun too when you're isolated on an island and the only medical you truly have was a clinic that got basically obliterated whenever you bring with you. So I think Moxie was the broadest spectrum we had. So usually anyone that showed symptoms was getting an air flight.
Yeah. All right. Well, listen, just I was waiting to see if my partner, for our dog and pony show, my pony, Dr. Jenkins is going to get on. I'll wait for a little bit longer, but otherwise I'll launch into the, into my presentation, today. So what I was going to first say though, I saw this coming across, and I don't know how applicable it is to us, especially in EMS, but maybe in general we should know about it, especially for the emergency department. But I remember I talked about the NDM gene, right? And maybe can you give us like a 3-minute blip on that, Eileen, and why it's important to us?
I'm sorry. What did you want me to talk about?
This new the gene thing that's very resistant.
Oh yeah. Okay, yeah. So they're talking about basically a jumping gene. It's a gene that goes horizontally across enteric bacteria, and they're focused on the one that's the New Delhi variety that is very resistant for almost all beta-lactam antibiotics. But when it transfers over that gene, it also transfers other enzymes that affect other antibiotics, leaving very few bacteria that are sensitive to any of the standard antibiotics that we use. Some of them are even resistant to colchicine, which is an old antibiotic that used to work. And we're often left with the idea of using phage therapy, which is using a bacteriophage against a particular bacterium that is causing a problem, assuming you have a bacteriophage against that particular bacterium when your antibiotics don't work. There are some very expensive antibiotics that have some efficacy in some cases, and I'm blocking right now on their names, but it's a very, very serious problem because it's mostly for gram-negative bacteria. It's almost exclusively a problem of gram-negative bacteria, but it's shared with E. coli, among others, right? Not Acinetobacter, Klebsiella. They're sharing this across completely different genera and order of gram-negative bacteria. And so it's spreading very wildly. We're seeing upwards of 70% of hospitalized patients with these kinds of infections. That makes doing surgical procedures much more risky, and just being hospitalized much more risky.
Okay. For some reason, I'm getting some bizarre thing here. Hang on for a second. I'm getting back to the Zoom here. Okay. Yeah, I don't know if it's really applicable to anybody yet, but just something to, especially in your practice, is that this is going to be down the line a little bit further. Hey, Don. So it may end up being a problem down the line. So we'll keep that in mind. And just we always keeping with Eagles. You heard it here first. So I just wanted to get it out there to everybody and so on. Let's go on. And anything else, by the way, infectious disease wise, nationally or locally?
Measles cases keep going up. That's another ongoing concern. Yeah.
Yeah.
Does anybody want to talk about the 4 different types of COVID vaccines that are available and which one does what?
Yeah, if we could do it, can you do a 2-minute thing, like 30 seconds each? Give me the elevator pitch. Yes, because I got to move on to other things.
So there's 3 messenger RNA vaccines available. There's one from Pfizer and one from Moderna that are the same technology as before, but with a new, but a sequence that matches what's circulating. There's a new one from Moderna that focuses on 2 parts of the spike, and the 2 parts of the spike that are the most important for the spike entering the cell. And then the last one, of course, is the protein subunit vaccine from Novavax, and it also targets the latest version. All of these work, all of them are good, but the one with the highest efficacy right now is the mNEX spike by Moderna, which only targets the receptor binding domain and the N-terminal domain. So, if you have a choice and you have no negative indications for taking a messenger RNA vaccine, that's the one to take. Remember also that when you use a protein subunit vaccine for any vaccine, you don't get as the same high quality cytotoxic T lymphocytes. In other words, the CD8 function is never as good as it is with these messenger RNAs, because with messenger RNA vaccines, the protein is made in the cytosol and readily presented with MHC class 1, 2 CD8 cells.
And you were hearing the same thing when you went to the messenger RNA meeting a couple of weeks ago, right? Is that right?
Yes, I went to a meeting about all kinds of messenger RNAs. Oh, by the way, the military is continuing to fund messenger RNA technology. So if you need a grant to do that kind of work, turn to the military, since DHHS is now a catastrophe.
Yeah, exactly. ACP called for the resignation of the secretary today in their formal statement. They put American College of Physicians, the internist. So interesting.
So did IESA.
Yeah. Who else?
The Infectious Disease Society of America also did that.
Yeah. Okay. All right. Well, let's move on to, let me just go. Anybody have to get off the call? Joe, you do have to go. Anything you have to talk about, for example, Joe Holly, since I put you on the spot before. And was there anything else you had to add to that conversation we talked about before?
No, my contribution was all I had. I've got nothing else really exciting going on. In relation to your earlier question, we did have a couple of Vibrio cases, particularly at Hurricane Ian, where we had lots of inundation and all that sort of stuff. So yes, absolutely a real thing in the USAR world for sure.
As well as electrical vehicles catching on fire, right? So, with our new, those kinds of automobiles are really doing something else. And then Matt, do you have anything report said you have to step off? Anything you have to tell us about, Matt Levy?
Hey, everybody. Hey, Paul, can you hear me?
Yep.
Great. Okay. Hi. Just very quickly, I'm going to be doing a webinar for NHTSA next week on the Pre-Hospital Transfusion Coalition's clinical practice guidelines. Happy to give you guys a version of that at some point in the future. Paul,
when are you doing yours?
It's going to be Tuesday the 30th at 3 p.m. Eastern. I'll put the link in here for anyone who wants it. But
today, what day is today? The 20th. What is it? I don't know. Today's the 20th.
Today's the 22nd. Today's the 27th.
So it's gonna be next week then?
On Tuesday. Yep, Tuesday 30th. Yep.
Okay, then give it to us next week if you want. Say, here's what I talked about, and I thought about it later. I was going to think about having you do like a practice run with us, but if you have to leave right now, then
I have to get onto a thing. Oh, Don's here, but Don knows all. Don can speak to me.
Hey, Matt, I'm just wondering, I sent you a couple of comments on that. I was just curious if you guys acted on those or not.
For which one, Don? For the
pre-hospital guidelines.
New comments or the previous ones?
The previous ones.
Let me get with you offline. I thought I did, but now you have me questioning.
I'm just asking. I was just curious.
I think I did, Don, but I'll reach out to you. Are you around later?
Yep.
Okay.
All day.
And Don, I got your email with the other thing, so thank you for the feedback.
All right, Matt. Hey, Matt, just as a warning to you, I'll be coming into your jurisdiction area, those areas on October 7th. They're doing a thing for Ray Fowler, and I'm going to be like an opening speaker on the 8th, and then heading off to down to Florida from there. But I'll be there maybe the evening of the 7th if you're around. Okay.
Let me take a look. I think I'm traveling that week, but if I'm here, I would love to see you, Paul.
Want to make sure
Matt, take those warnings very seriously. When Paul comes in, it's an event. You got to put all your other things aside.
I know. We opened a special terminal at the airport for him, so it's good.
That's great. Yeah, and of course, some disaster always happens whenever people. That's why I'm forced to give you a warning when I'm coming into your area, right? So, hey, Chris, anything to report? You're going to have to get off pretty soon, but anything? I was saying nice things about you yesterday, by the way. So and we established a boulevard in your name there in the Dallas area.
I saw that. I appreciate that. I'm happy to come out for the christening anytime you like. No, the one interesting update just this last couple of weeks. So as you probably know, we've had at UCSF San Francisco General had a number of federal grants that were either paused or canceled over the last 6 months or so. We did just find out this week that we had one R01 and one K23 that were approved to go forward. Unfortunately, they weren't. Only one of them delved into the pre-hospital a little bit. The others didn't, but it's very interesting what wording is necessary now in the federal grants, and it's not going to be a surprise to anybody, but what needs to be taken out and what needs to be put in to get approved. But this was our first approval in the last 8 months, really. So, and anyway, that part is a good part. We're doing the same struggle with finances and outlook as everybody else is.
Yeah.
And we've been busy, high acuity stuff. Everybody's falling off balconies. So good excitement around here.
Okay, got it. Terry, you had something quick to say before I move on? Terry Valenzuela, you had your hand up, or was that by accident? If we don't hear from Terry, then I will move on to Mark Gautreaux.
I do owe Terry a response to an earlier one from almost a month ago. I'm sorry, I got way delayed. So I'll follow up with you, Terry.
Okay, good. How's Jane doing? Okay, tell her I said hi. Okay.
Yeah, we got the virus going around at ours. I don't know if it's COVID or flu. I've stopped testing for this stuff, but we got something going around the house. She got it. She got it bad, but she says hi.
Okay, good. Probably COVID. All right, got it. So let's go then to Mark. Let's go down the peninsula a little bit there. Mark, anything to report from your end?
Yeah, no, I mean, kind of similar, experiencing very, very high volumes, a lot of acuity. Not quite sure what that is. Kind of statewide.
Are you saying in the emergency department or EMS or both?
Both, kind of, actually.
Yeah. Okay.
And I know this is going around a lot nationally, but we're also starting to see a lot of hospital closures out in the rural areas.
Yes.
Out in Glenn County, I think, has announced abruptly that their emergency department will close in, I think, 4 days from now.
Yes.
And I think 35% of the rural hospitals in California are at threat of closing. So we're anticipating bad times are coming.
Yeah. Hey, Kim Landry, you're up on the peninsula there to some extent in Florida, not the peninsula, I'm sorry, the panhandle. And tell us about that. Are you seeing closures or closures being threatened? We know we had one already in Brevard County, but tell us about that.
Yeah, we've got a very small kind of critical hospital that they're struggling, but they're still open right now. And I don't know that we have any others that are being threatened, but there are several here in the panhandle of Florida and in adjacent Alabama that actually there's the one in adjacent Alabama and that's probably going to shut down and convert to maybe a freestanding emergency department because they simply are just dying for help. They're wanting us to bring all our patients to the emergency room there, but they don't have the physician support to treat them. Yet they don't want us to transfer them out of town. So it's really complicated, but yeah, we are seeing the effects of these rural hospitals not having the financial backing they need to stay open, and they're struggling, and they're desperate for us to bring them their business, but they don't have the infrastructure to treat the patients accordingly.
Yeah, we were talking in our meetings last year, right, about OB deserts and so on. And it's got to be a lot of deserts, that are going to be happening. And that's going to be, and if you are running in, we're all metropolitan for the most part. Some of us have non-urban areas, but it's still, for the most part, it's a terrible thing because if you have one or two ambulances for your whole county, perhaps because it's whatever, and now you have to leave, it's a terrible choice or a terrible situation for them. So. And, helicopters not running all the time and they're expensive as well, all those kinds of things. Right. And then that's why Charlie was just noting that's why telehealth is critical, but it's still not optimal if you still have to, have somebody, examine and taken care of and diagnostics that were done, but all the above. All right.
Hey,
well,
Paul.
And actually with the implementation of Pulsera, that has really helped in some of these
Okay.
rural communities, because the paramedics get on scene and they identify, maybe a patient really doesn't need to be transported 40 miles to the
Right.
hospital, and they can contact me, and I'll do a video virtual visit with the patient, have the paramedic help me do the exam, and a lot of times we can avert a transfer.
Yes.
And so, yeah, Pulsera has really benefited us in that.
All right. Let's go
Paul?
on to Jim. Yeah, Jim. Yeah, go ahead, Jim.
The national data on the small hospitals and rural hospitals, they transfer so many patients. Our national average is now up over 5% of patients seen in rural and in low volume EDs are being transferred. So they, there's still sick patients that live there and want care there, and then have to be processed and then transferred to one of the bigger centers. So
Okay.
it's not that they're low acuity all the time.
Yeah. All right. Well, I've been stalling a little bit, waiting to see if Jane Wigginton was going to come on with us, like she told me she was going to, but apparently has not shown up yet that I see. But I think we'll go ahead and get back into it. Unless anybody else have to get off before Don and I launch into our next dog and pony act, and we all know who the dog is, right? Like Don. So the Don, I should say. Anybody else have anything else before we move on to our next subject? Because this will take about 15 minutes or more. So we just wanted to make sure we tidied everything else up before we move on. So anyways, Don, you want to do the setup, which is largely, I could say it in 10 seconds, which is that it seems that in all types of emergencies, women seem to have better outcomes. I should say critical injuries, right? Critical illnesses as well. Women seem to have better outcomes. And so the question is, why is that? And so we think we have some insights into that. So do you want to start that off and just give a quick repeat, Don, because we covered a lot of that last week, correct?
Yes, Paul. I'll tell you that there's a couple of other interesting things we've uncovered that I haven't had a chance to tell you about yet. But one of those I had hinted at, and we needed to do some verification on it. But when it comes to the development of trauma-related acute hypocalcemia, it appears that women are more resistant to development of acute traumatic hypocalcemia than their male counterparts, significantly so. And that's injury for injury. As we have also been able to show, the higher the injury severity score, which is relative to the injury burden, the more likely that there is going to be acute hypocalcemia, and the worse it is. This is not that true amongst women. So that's an interesting thing. The other thing
it helps me, and it drives me as hypothesis generating for me in terms of the mechanism of hypocalcemia that you and I have debated back and forth, in the past. So it may give us a new hit, right? So that's interesting. Go ahead.
Well, yeah. So calcium is such an important cofactor in clotting, right? Which then may help us understand why their plasma and their platelets work so much better than their male donated counterparts, or tested counterparts for that matter. The other thing we uncovered was this interesting thing. Is that when it comes to this NHTSA crash data fatality analysis reporting system, that as it would turn out, in the states of California and Texas, we only looked at 3 states for this so far, the other being Florida, but in California and Texas, women are significantly more likely to be alive on scene in these fatal car crashes than their male counterparts. And I proposed that to Holcomb, and he said he thinks that, well, maybe that's just an indication that women are stronger. I said I thought maybe it was just an indication that they still wanted to get the last word in. But,
women are smarter. That's why they're smarter.
Yeah. So it's interesting. I'm celebrating my 35th anniversary here, and actually in New Orleans. And they said, "How'd you last so long?" He said, "Well, we argue every single day." And I said, and I got to the point now, I'm so good at that, is that I always have the last word, which is, "You're right, dear." Right in the end. No, but it's really funny, But I think that to answer your question, Eileen, we're going to give you some insight to it in the next few minutes. Presentation that would do that. At least may give us a hypothesis generating approach to all this, right? As we go through this. All right. So in any event, so let's go ahead and proceed. I was just looking, I was stalling a little bit to see if Jane, who did a lot of this work, was going to try to pop on with us and give color commentary since she did the work. I'm just, pretty much, I was a co-investigator with her, but she was the primary on this. So we'll go ahead and do that. So you ready for me to launch into that, Don, then? Are you cool with that? Okay, good. All right, so let's do the share thingy here. Okay, there we go. And then here it is. So as I called it, I'm going to skip through the first part a lot because I gave a lot of this last week, okay? But let me lower this thing here. Here we go. So can everybody see this okay? Anybody out there that can say they see this okay?
Looks great.
Yes, we can see
Okay,
it.
good. Fantastic. All right, I'm going to skip through a lot of this real quick because we did it last week, but I'll just emphasize a couple points. What I'm going to lead to is that not to bury the headline, is that I think that a single dose of estrogen infusion, and we have Premarin around already for various things that we do out there, uterine bleeding and things like that. It's been safe. It's inexpensive, relatively speaking, especially if the cost, if it stops in ICU, if you have to go to an ICU, well, it's very inexpensive and high probability of effect based on the incredible amount of laboratory data. And I think it's just time for us to move on into the pre-hospital setting. We did write about this. Jane's the first author about this about 10, 15 years ago, and gave the rationale based on thousands of pieces of information that's out there. And I talked last week about how we came up with this, line of investigation in terms of she wanted to know, is women's outcomes, is especially in STEMIs and things like that, they had worse outcomes. Was that sociological or biological? And I said, well, let's take something that we know is, it's easy to diagnose and everybody gets the same treatment, which we did show in the study. Was cardiac arrest, and overall the survival was so much better for the women. In fact, if you look at the younger women, during the hormone phases, I would say, of their lives, right, the high estrogen levels, etc., is that the women, no matter whether we did in hospital or out of hospital, that whether we did VF, the double survival rates, PEA, you could see here, you can't see very well, but I'll just trying to get through this quickly. Even PEA and even asystole. Yeah, the older women and men had about the same poor outcomes, and this was to hospital resuscitated to hospital admission. And later we found out this correlated with, long-term discharge, so on. We did not do neurologically intact survival at the time, but the younger women, was double what the men were, like even in asystole, let alone PEA and all the other things. So one of the things that we found that was very interesting was that she there was we thought we'd come up with something interesting here, but it turns out there was so much literature. People like Irshad Chaudhry out of University of Alabama, you knew him, right, Don, etc., and did a lot of this work. It's like unbelievable, and most of it shows to a neuroprotective effect of the estrogen. In fact, one of the things that was interesting is that Jane did some studies early on where she was looking at the outcomes, particularly of men after serious head injury. And one of the things she did was actually looked at the ventriculostomy fluids. She actually found men who had good outcomes at high CSF estrogen levels that are not typical. Like for some reason, your brain seemed to produce estrogen as a protective effect. And those who didn't have the high levels, they did poorly. So if the spinal levels were less than the serum levels, then you had more deaths. And she was finding that the serum levels were like, for the men that survived, had like 10 times the amount of spinal fluid levels and so on. So it was kind of an interesting observation there as well. So at least we had a clinical indication that something was there. Later in the laboratory, she showed that there was increased aromatase expression, et cetera, that might be responsible for it. So we don't know if that's a natural reflex to do better or whatever it is. And no other hormones change to the same scale as estrogen. So maybe we want to know, are they directly protective? Are they, importantly, is it therapeutic actually? So so that's an interesting thing. Should we give it to you? Yeah. And so the answer is yes, based on all these numerous experimental studies that I was referring to, and they all point to the conclusion that sex steroids and to some extent progesterone as well do influence the degree of injury and recovery. So I'm going to focus on estrogen because that's where Jane did a lot of her work out of that. And so if you look at things like here's testosterone and the 5-alpha, dihydrotestosterone, they all kind of look the same to all of us, right? A little bit difference out here and so on and so on. Progesterone almost look pretty close to that, but they have different kinds of moieties that are hanging. But the estrogen thing that we think really is the key, literally, physically, almost like a physical key that makes it work, is this whole area down here, all right? And that becomes important because it gets you into the mitochondria. So this gets past blood-brain barriers, it goes into the cellular, and it goes right into mitochondria, as you'll see here. So in stroke, TBI, spinal cord injury, trauma, sepsis, cardiac arrest models, early IV administration of estrogen has been shown to provide significant protection, all these. And this is even after the fact, both before and after where it had some help there. So this is a classic one that I think I showed you last week, and I showed in the invitation, is that this is the effect of estrogen treatment at 40 minutes after a middle cerebral artery occlusion. So all of us thinking about strokes, this is fairly interesting, right? And you can see here's the rat brains. And so this is obviously the placebo side where you see these infarction areas here when they later were, examined post-death. And over here, and then you can see there is still some injury, but not so bad as you look at this side. So that kind of things like that are striking. And so that tell you anatomically even that things are happening there. So, and that was at 40 minutes. And what we're going to talk about is studies that we did where we said, let's do it within 15 minutes of the burn, of the injury, of the stroke, whatever it may be in the clinical situation. But what was fascinating for me to find out was that the protective effects of estrogens were neither cell type nor insult specific. So what I'm getting at is so it's not just the typical estrogen receptor sites we're talking about. We're talking about every cell in the body. And it has anti-inflammatory as well as antioxidant and other protective properties that are conferred in the body, almost any cell in the body, matter of fact. And that neuroprotective effect is not fully mediated, again, by the usual estrogen receptors. It just seems like this can get into just about every cell. And the bottom line is what they started finding out, and look at this is 2005. So that's why we were into this about 15 years ago. These were Dr. Simpkins and his group basically showed that the mitochondria play a central role in estrogen-induced neuroprotection. So if we talk about apoptosis being the old misery loves company, process that occurs out there. Well, this seems to protect that from happening. It kind of upregulates those mitochondria, so it kind of fools things into thinking, okay, we're okay. We don't have to, go apoptotic on everybody. So the other area was, especially there, we had the Parkland Burn Center. We had a laboratory up there, so we thought we'd take advantage of that in that situation, and we started with some burn models in the lab. And what's interesting is that the things we see like ARDS that comes out later or various other things are mental aberrations and burns. Okay, it's not because they're sedated. It's not necessarily because of they're getting septic and so on. This is actually it's IL-6 and various other mediators that are going out systemically. So it goes to your brain, it goes to your heart, liver, and it goes on. So even if you had a truncal burn, it affects every organ in your body because, and I'm talking about within 5 or 10 minutes, IL-6 is just getting out into your bloodstream and moving everywhere. And so ARDS, which is the most common thing that you'll see as not necessarily sepsis, but ARDS is mediated by that. And we'll talk about that in the next few minutes. So what is this one? This is, if I remember, I think this is looking at the eschars. Yeah, because you think, why should we? The Burn Center found that people did better if they removed the eschars early on, and we're going to show you why. Okay, so here's IL-6 levels, as example, in the skin. Okay, which is in the sense in those eschars, right? This is a sham burn, so we had a control group, so to speak, right? Didn't have burn. Okay, and then over here is a group that they got burned, and these are the IL-6 levels that take off like that. But if you got estrogen here, okay, what happened was 7 days after the burn injury, your eschars were not showing the same level of IL-6, okay? So that was pretty interesting in itself. So the eschar levels at day 7 are really almost near what you would say control group should be, et cetera, versus what you're seeing out there. And that sort of gave us a good indication of why we, why the eschar removal seems to be helpful under those circumstances. Then I mentioned this thing about the pulmonary inflammatory response. So that, it's not sepsis, it's the ARDS is really the IL-6 attacking that area. That's the most common problem and cause of death, I think, in most of these patients. I don't know if things have changed in recent years, but that was my experience all along being the pulmonary doctor in the ICU. And what they found was if they gave post-burn estradiol, and this is like within 10, 15 minutes, it decreased that pulmonary inflammatory response and improved lung function following experimental severe burn injury. And we presented this back in 2010 at the Congress on Trauma and Shock. And here's it is at all time points following one single dose of estrogen given out here. Here's your control group here. We talked about, here's IL-6 lung tissue levels here, right? And look at this. This is the estrogen along here. And this is 1 hour, 2 hours. And these are now getting into 7 days, 45 days. So you could see that one dose that we gave right there, oops, sorry about that, hit the wrong one, right there, did all this. And this is the tip, this is the IL-6 levels you're seeing in the lung over those periods of time. These are just incredibly conscientious and very comprehensive studies that she did on these animals, a lot of them. So she also did pulmonary function testing on the rats here. And as you can see at all time points following the severe estrogen maintained normal minute ventilation. Here we are. Here's where you got your dose. Oh, at 15 minutes, there it is. That's where I remember now. And then you got your control group, which is in yellow, which you can't see very well here. But here's the estrogen group. And you can see it just maintains it at normal levels of minute ventilation. And you can see what's happening out here with the animals having to breathe very hard because they're in deep doo-doo at that time. And we also looked at oxygen saturations, and you could see here, same kind of things. There was a little bit of a dip here, apparently, food, but this is one dose here, but for the most part, it was protective as well, okay? So the next thing was, a lot of people have altered mental status because they're getting pain medications or they're getting whatever, but it turns out that actually there's a brain inflammatory response that occurs as well. And that's probably what's going on. You'll see why this becomes important later, not just for our stroke patients, but for even things like Alzheimer's and so on, and people who have a severe head injury. So estrogen treatment following severe reduces the brain inflammation as well, and also that apoptotic signaling. And I'll show you some of the apoptotic signaling studies that were there. And this is, we have a lot of this is out there. You could see it for yourself, et cetera, and so on. So, and by the way, I'm going to show you, here's the IL-6 in brain tissue. Again, same pattern, right? Look at this. Here's the estrogen staying, looks right at the level of the control levels, one dose only. And then look at the levels that are going on normally in our burn patients that you see. Okay. Again, these aren't burn patients, but we think it is. On the other hand, she did look at things where estrogen levels looking at activated caspase, which is actually one of the things that does apoptotic signaling. Okay. And 24 hours after severe burn injuries in rats, again, she's showing that the levels remained of the caspase remain low, your control level, your estrogen levels, and then the apoptotic signaling for this caspase 3 is a little higher there. So there's just all these indications here that we're finding that go there. So I want to just stop there. As Jim or anybody out there, Don, anything you want to say at this point before I move on, because it's going to get kind of interesting now. But you're hearing me okay? Am I okay at the cadence and timing wise?
Yes.
Okay,
Yes.
good. And you could follow this okay. Okay, good. So getting back to where you were, Eileen, I'm wondering how much this is a mitochondria thing, et cetera, whatever. We'll see as we go through this. So this is kind of interesting. There's a thing called sonic hedgehog, which I had no idea. I didn't know about this, but it's a signal protein for neurostem cells and repair following indirect brain injury occurring after severe torso burn. So again, these animals were just burned in the torso, but you find we looked at kidneys, we looked at liver, it's all the same stuff. I didn't want to bore you with all the studies. But and so what we did find was that sonic hedgehog levels are amplified. Okay, here under these. There's the estradiol in the purple color again. I'm sorry for the people who are not who are colorblind, but I'm at least showing you that the sonic hedgehog are amplified, and so it really helps out in a sense from that point of view as well. All right, so yeah, there's another picture of it, day 45, etc. This is what sonic hedgehog apparently looks like, by the way, for those who are dying to know, right? So it just all these different angles, and that has a lot to do. Even we'll talk about later about not only with someone who has a contusion or possible concussion syndrome, but it also could be important for people. Even we found out with Alzheimer's, which that's a whole nother topic, but it's interesting there. All right, but let's go to the trauma hemorrhagic shock models. Yes, there was work done. So here's Irshad Chaudhry's group, I believe, who did this one, looking at maximum bleed out volumes, and that the 60%, which circulate about 60% of the circulating blood volume for them. And you can see the rat receiving estrogen survived 3 hours longer after MBO, after they reached that point, whereas there was only about an hour for the other rats, et cetera. So the implications for this go along maybe with some of the other things we're talking about. It's just the observations were tremendously promising. Could you buy time with it or whatever it might be? And so this is all out there for you to read about if you like, etc. There's Irshad. And unfortunately, he's retired. I'd like to bring him back into the fold because I want to always give him credit for this incredible groundbreaking work that they were doing. This is published in 2015, but he was doing that work in the 90s, and just impressive. We thought we had come up with something new, but these guys were on it for the longest time, etc. And I like this. Here's the conclusions, and I'll blow it up here a little bit for you. Administration of a single dose of 1 milligram per kilogram of the estrogen that they were giving in saline after severe hemorrhage increased survival in rats by 6-fold. Partial recovery of blood pressure values correlated with longer survival time. These results, coupled with similar findings in a companion study in mini pigs, support the further product development of this particular formation of estrogen for severe hemorrhage when standard fluids are not available and situations in which prolonged transportation periods are required for definitive care. So I'm just saying there's a lot of work out there. I'm like ready to go and use this stuff. And here it all comes down to upregulation of mitochondrial respiratory complex IV by estrogen receptor beta is critical for inhibiting the apoptotic signaling. So these are other people in other countries, but working with Irshad, finding all the same stuff I was talking to you about that others had found as well. So just want to show this is like in trauma hemorrhage, it may be a really important adjunct for us to give. And most importantly, as it goes, it's safe. I would give it to my daughter if she needed it under these circumstances, and it has been safely used already in severe uterine bleeding. I talked to my brother's an OBGYN doctor. Yeah, we do it all the time. It's not that expensive. And they've used it in advanced prostate cancer in adolescents with scoliosis, with postoperative blood loss. So it's been around for a long time, and it's been safe under those things. Now, what comes back to this talk that Don gave, right, when he was talking about the salsa verde, right, the green plasma, the green tinted plasma, when they found out that was related to women who took birth control pills, estradiol, and so what happens when that gets absorbed down below, it does have a first fast pass effect in the liver, and that gets conjugated, and it gives you your higher propensity for blood clots and so on, and so anyways, but it turns out it's probably good for us to have that kind of plasma to give because it works a little bit better than standard plasma that we give and those things. But in this situation, we wanted to give it IV because it bypasses that first pass effect. It doesn't have the clotting factor effect. We're doing it, and that's why we're going IV under these circumstances, which is believed to be responsible for the estrogen-mediated blood clotting effects when you go through the oral administration. So that's kind of an interesting thing that we may have two things that estrogen does for us. One, if we can conjugate it in the liver, that'll be helpful maybe. And then also, if you give it IV with this stuff, we protect the mitochondria, prevent apoptosis, et cetera, right? And it's relatively inexpensive. I think at the time I gave this presentation 10 years ago overseas, the IV Premarin was, when you get the dose of about 100 euros retail, which is about the same thing for us. But again, compared to the cost of keeping them going into an ICU, obviating an ICU day would be really worth doing. Anybody ever seen that before, an empty ICU bed? I think it was waiting for the next patient. That's what it was. So overall conclusions are that resuscitative endocrinology research, I think, should be reprioritized. Reprioritized is what I should have said here, right? And that we have now become sex therapists, possibly, right? That's kind of cool. Trust me, I'm a doctor. And on the 22nd century, the dead shall be raised, we hope, and will make life better for future generations. Oh, wrong slide. Here we go. Make life better for future generations. Here we go. So merci, everyone. Oh, yeah, I think I must have given this talk in Paris. I think that's why that's there. All right. Any questions about that at this point? I'll stop sharing, etc. Okay. So anyways, Don, any comments before I go on, are you waiting for I'm sitting here going, I'm not even waiting for if it was my daughter, I'm not even waiting for the RCT on this, right? Because there's enough evidence here, but any reaction though, Don?
Yeah, so it's the upregulation of ceruloplasmin in the liver on those high estrogen women that accounts for the oxidation of that copper, right? Gives it a patina to the plasma, and it's really effective. And so we have taken that on here in the state of Texas. We are going to push a statewide initiative for increasing blood donation. We've coming up with a campaign to make sure the public understands there is a greater need with this pre-hospital whole blood pilot program that we're trying to put out there, and we have accepted as a state that if whole blood is unavailable, that plasma could be a suitable substitute for it, and that we are seeking new affiliations with Planned Parenthood and the college campuses to engage those young people to become new donors to fill in the supply. And I think we're going to see more green plasma enter into the donor centers.
Yeah. So it's interesting from that point of view. And then also the administration of this drug, like a Premarin, would be fascinating if that we as well as just another adjunct that we could add to along with our TXA, et cetera, out in the streets as well. And hopefully it would decrease the amount of bleeding, but more importantly, the long-term injury, et cetera, that we have, under those circumstances. Eileen, I don't know if that answered any of your questions, but what are you thinking in response to this?
Well, I mean, certainly hormones have huge effects, but there's so many interesting gene differences and epigenetic differences between men and women that I think the jury is still out in explaining this entire process. But still, I found it fascinating. And thank you for mentioning Sonic Hedgehog. It's one of my favorite proteins. When I hear that, I always think of T regulatory cells and how they're impacted.
Yeah. Okay, got it.
Paul?
Yes, Jim.
I'm sure Art Kellerman talked to you about progesterone and the early signals for traumatic brain injury that progesterone could be protective. He was involved when I was at Emory in looking at progesterone, and probably some of those signals were coming from estrogen at the time instead, and they did not find progesterone to be neuroprotective.
Yes, yeah, and that's why I wish Jane was on, because she could tell you that exactly right. She did a lot of that work looking at all that. And estrogen was changing, particularly with head injury, a lot more of that. This protective effect, where like the body knows to upregulate with the aromatase expression, is just fascinating. That it knows to turn it on, but in the people who didn't turn it on, they had worse outcomes. So I hope this was interesting for people. I'm trying to give you a glimpse into the future. And by the way, I found out here in my hotel room that they actually they said they thought it was appropriate that I had a crystal ball here. So there you go. So anyway, so I'm hoping I'm giving you a view into the future as well, et cetera. And then for Ken Shepke, I just want you to know, I hope I did use the arrows when I had different kind of colors up there. Okay. And Ken knows what I'm talking about. So, which is good. How are you doing, Ken? Anything new to report from us, for us, by the way?
Yeah, there we go. I think I got the camera open.
I can hear you, but yeah, no camera yet.
There we go.
There you are. Yeah.
Fascinating lecture, Paul, and I know we've discussed that before. But I think women are just tougher than men to begin with. It even starts at birth. I mean, honestly, we know that the female baby survives better than male babies. So there's a lot of reason why they're stronger than us. Just report stuff. On the discussion we were having earlier, a couple of things we're doing at the state, and I heard Kim Landry talk about using the Pulsera app. You know, we have that statewide in Florida now to allow our medics to do that telemedicine stuff. And I don't get too far off topic. I'll go to the blood stuff in a second. But one of the issues that we have, while that's very efficient for rural health, EMS doesn't get the bill for that. But I got it approved to put it in one of our Department of Health bills this year. Good. To allow EMS to get paid for treat and release and alternate care destinations. So we'll see if that passes, but it's going to go in as one of the Department of Health's bills. And as far as blood, that did get picked up. I've told this group before that Florida's looking to we're trying to get $15 million to do blood and plasma statewide. And that got picked up by the governor's budget too. So hopefully we'll have the legislators go our way this year, but we've got two good initiatives in Florida coming through.
Well, this is great. Thanks for joining us today. I know you're so busy, so we're very flattered to have you on our call today.
Ken,
usual.
Thanks for the work you're doing for us. You're making it easier in the field. Paul, that crystal ball is only there in New Orleans during hurricane season, just so you know.
I thought the general manager had put it in the room for me along with the champagne for my wife. So, all right. Well, listen, which actually just real quick, have you guys, I don't know if you and Ken talked yet, but just as a 30-second nutshell, Ken, Jim could say is that when you did some programs like the CORE program, it ended up helping him with other programs in the community as well. You want to give us a real quick shout out on that? Because Ken was asking me what that was on the agenda for when we go to Brevard County, right, Jim? Yeah. And so he said, what were the other programs? So I said, okay, well, let's see. So Ken started this program where we set up kind of, in a sense, well, you want to call them, opioid resuscitation centers, right, to get things going for what better. So you have designated centers that will help get that advanced. So you started using that, and then what happened with it afterwards, Jim? So Ken knows what you're going to be talking about. So,
Ken, we put the CORE program funding in place last August in Lee County. For everyone, Lee County's 860,000 people. We do 110,000 EMS runs per year. The next quarter, our runs dedicated to opiate use, potential opiate use, went down by 200 per month. So that's 6 less calls a day related to substance use. And that has continued for the rest of the year. That served as the pilot funding for the rest of our community paramedicine program. So it's been effective, and thank you.
That's fantastic news. You know, that started as a Palm Beach County Fire Rescue Program that I brought to the state, and the governor agreed to let us try to make it statewide. It's now statewide. And just Palm Beach County, since we started, our 911 calls for overdose has dropped by close to 80%. And our death rate for opioid overdose has dropped by more than 2/3. So it's very effective.
And I have to give a pat in the back to Ken, because that early study he did it long before, because the pill mills were out there in Palm Beach County. It was one of the worst in the country. And he got this whole program going, there to get people on Suboxone, having the paramedics part of the team that was doing it. And they started right in the emergency department. I could go on and on. But what I thought was really great about what he's doing, because other people had been doing it, but not like what he did, which was did really close follow-ups with blood levels, not for other opioids, but also for the Suboxone. And actually, in other words, he was checking compliance right out to what, a year or something like that, Ken? Is that right? And what, 80% effective? They were all compliant. Is that right?
Yeah, that's absolutely right. So, and I don't want to take too much credit. This was a whole team effect with Healthcare District Palm Beach County, one of the HCA hospitals, JFK Medical Center. So there was a whole team, the attorney's office, et cetera. But yeah, we check compliance, and not just at the 1 year mark. We checked it, every single visit to make sure they're still taking buprenorphine. And what we found, they stayed in the program for 3 months. The overdose rate for that cohort went to 0. I mean, and I've got people in it now. They've been in for 8 years, still doing great. So it's amazing. If you treat chronic illness with medication, people actually do get stabilized. So it's a phenomenal thing. as opposed to expecting to take 0.
Yeah. Okay. Good. All right. Well, listen, thank you both. I was just glad to have you on. I'm going to go on. Hey, by the way, Tomas was on, and thank you, Tomas. I wanted to say hi real quickly. And I just want you to know that article, the studies I published are in Critical Care Medicine. So I'll try to send you a copy of the article about the estrogen. My recommendation, we routinely give it. But about the CME, I'll get information to you about how to join. How are you doing? You doing okay?
Yes,
Tomas,
thank you very much.
remember,
Yeah,
he's our editor-in-chief for Critical Care Exploration. Oh yeah, that's a good, Ken, the place where you published your study about the, the using ketamine as for the benzo-resistant, that's Tomas's journal. Okay, so just so you know, that's good.
Very nice.
And how's that going? Okay, Tomas, is that your work on the journal
Yes.
going well? Okay,
yes,
good.
I think we have put out a really strong September issue. I recommend everybody to have a look at it. It's very varied. And thanks for the help with the CME. Other panelists have reached out, so I'm in the process of getting that sorted. Thanks.
Oh, great, because so I don't have to follow up on it. You're on top of that, right?
No, thank you.
All right, good. Okay, that's one less thing for me to do today. That kind of thing. Hey, listen. Let me talk real quickly. Hey, David Gordon. I'm really glad. David's an emergency medicine person who also does, well, almost all the time now, critical care medicine up at Washington Hospital Center, and in DC. I got the privilege of doing grand rounds for him. Okay, and just. I was one of those things where he was going to, if I did a bad job, he was going to tell people it's someone else's idea. If I did a good job, he's going to tell me his idea. But if you don't mind, then whoever gave the help to Tomas, if you could do it for Vicente as well there, I see that I'd appreciate you helping me out there. But David, anything, you were going to make a comment about testosterone? Is that right?
Yeah, I'm not super familiar with all of the testosterone literature, but I think there's testosterone literature for looking at maintaining muscle mass and recovery for critically ill patients.
Yeah,
because that's such a big problem on the back end. And as I was thinking about that, I was looking. It looked like at least one trial was enrolling people for during their ICU stay, starting them on testosterone to help maintain muscle mass.
Yeah, go ahead.
I was going to say probably the role of sex hormones in ICU care is probably way understudied and misunderstood, and probably all the endocrine pathways that we need to look more into. So thanks for that.
So
and it was great to have you here. We loved it.
Okay. Washington Hospital. Yeah, we loved it too. Although you were forced to have me have dinner with you guys the night before, that was miserable at that place. David will tell you, we had a great time at Philomena's, one of my favorite places down there. It was really good. It was a great group. Oh yeah, I'm sure you are. It was a great group of people, and I'd love to come back again and do things like this, for example. Jane's work showed that testosterone had a negative effect, interestingly enough, and so it may be just not that they have the estrogen, maybe the men have the testosterone. On the other hand, so maybe use early on estrogen to get resuscitated, and then later on, a couple of days later, you go ahead and put the test. Once you got them resuscitated, you get the testosterone on board when they're waking up, etc. I don't know. It would be interesting, correct? So it's kind of fun. So thank you for joining us. And if you have any topics that you could bring up, that'd be really good for emergency medicine, that are based in the ICU, or especially if it's pre-hospital oriented, we would love that, David, from you, because you're such a great educator and a great person to hang with us. Okay. By the way, he'll fit in with us really well. I'm going to try to get him down to Eagles next year. So thanks for joining us. So, all right. Okay, so then I think it may be time to go around the room. Dustin, you had something you wanted to pop in at a sort of and we could have you do it next week, or you could do it now. I don't care. What do you have in mind?
This is just 2 seconds. So
okay,
somebody
you're finished. 2 seconds. That's it.
Nice.
No, go ahead, please.
Somebody was mentioning Pulsera and how much they loved it, and then Dr. Sheppy was mentioning some programs they did down there. I just wanted to mention, with the $50 billion thing, the rural health improvement funding that's out there, each of your states is getting bombarded with requests for that money and proposals for how to use that money. So if you have an interest, if you've had good experience with Pulsera, something like that, I would recommend reaching out ASAP to your state to weigh in on that. Ours in Ohio already reached out and said that ESO has reached out to them with a proposal to do basically what Tele 911 does and what some of you are doing with Pulsera. I have my own opinions about whether they're the right organization to do that, and whether that's something they've actually done or just trying to develop with this funding. So I've expressed my opinion in the state there, but I would recommend being active in this because you have a lot of ability to weigh in on what your state winds up doing with that money in some cases.
If people want to know how you go about doing it, like what do I have to do when I get off the call here or whatever, would they be able to reach you and just reach out to you and say, here's how we did it?
I can do that, certainly, but it's totally state specific.
Okay, got it. Ted, go ahead and weigh in on that then.
Yeah, I was going to say that I can only tell you how it works in Florida. I don't have experience with those states. It may be similar, but the way you would get something like this done, the way Pulsera did, is they approached a single member, and it's called a member project. And each member, they put in their own. They're allowed to have a set number of bills or projects they can put forward. They don't all get passed, but this Pulsera had a significant amount of favorable push from both from us at the Department of Health and also from the industry. So that kind of got it over the finish line. So you really have to organize in terms of the various folks that would be interested in this. That would include your Department of Health or the equivalent, if it's not called that, your fire chiefs, your EMS organizations, your ambulance organizations, and even your rural hospitals. And if you get all that as a coalition together, you can get something like this done. And for us, it's for the folks that are like Kim that are using it, it's really great, especially for the rural areas. But they've been using it in Polk for a while, and Polk's, it's got rural parts, but Polk's pretty well developed. And I don't know if Paul Banerjee's on today, but he's showed significant, significant drops from 911, the cath lab, both for stroke and for cardiac. I mean, it makes real world better outcomes for patients. It's not just communication stuff. I mean, he's actually making the process from 911 to hospital outcome much better because for all these time sensitive diagnoses.
Yep. Okay, good. Well, thanks. So anyways, does anybody wants to assist Lisa to see what they're doing there as well in Ohio, then please reach out to Dustin. Thanks for that real timely suggestion. So it's important for a lot of places. Again, with the whole issue of the OB deserts, let alone the other kinds of deserts. We had a debate that Charlie Sands will tell you about that we did in recently in Tampa about that, and whether people should always go down from a low inhabited area, go way out of an hour or two later to get to somewhere else. Peter Antevi, are you around today? Can you make a comment?
I'm getting around is what I'm doing. Let me lower my hand here.
What kind of car is that you're driving in?
It's one of those electric ones.
Yeah, got to keep it away from the salt water, right?
Yes, yeah, I do. Okay. I'm waiting for it to die. The battery's still going after 5 years. But I just wanted to make a quick comment on the rural thing. So there was a webinar put on, I think Doug Kupas was on it. It was done by NAEMSP nationally. They talked all about the rural funding that Dustin and Ken just mentioned. So I'd recommend people do that. And then, that's pretty much about it.
Okay, got it. So one thing I want to say just generically to the group that's still here with us, because the people are going to be signing off pretty soon, and I'll pick on people we haven't heard from for a while, like Chris Zuver, except. But what I was gonna hang on, you need something? Okay, here, I'll give you a piece of paper. But anyways, I just want to make a general comment that a lot of the talks that we have here are people bringing it to me, whatever notes they have, they wanted to talk about something like Dustin just brought up. Please let me know. I want to put everybody on. Everybody have a chance to give a topic of du jour that they want to talk about. I don't want to be coming up with these things. I'm very fortunate that people like Amal Matu reach out to me. Amal would have been on, but he's on Lake Como or Lake Garda, I think, today with his bride, having a great time. So, but I'd like to hear from you guys. If you want to talk about a subject, please let me know and I'll put you on. I'd like to do that, etc. So, all right, with that, let's go over to Chris Zuver because I haven't heard from you in a while. I'm glad to know you're alive, Chris. And so anything we need to report out of either Orlando or Orange County for us? If you're there, Chris Zuver, this is great. Lacey's tuned into the call here, so it looks like. All right, then if not, I'll start moving around to some of the other folks. But Chris Suver, if you're there, please go sign on board. I really appreciate hearing from you. All right, then let's go ahead and move over and talk to a couple of the other people on the line here. Crawford, you weren't on last week, so anything new that you could get for us this week? Okay.
Yes, actually, a couple of things. The city of Philadelphia this week has issued an RFP for medical director of the fire department. And
no kidding. Seriously?
Well, let me so essentially this is a different type of RFP calling for a chief medical director, a deputy medical director, and an attending medical director, all of which positions are basically going to be like 0.9 FTEs, or so basically full-time jobs.
Okay.
And I have been unofficially assured they're not trying to get rid of me. They're actually trying to get me help, which
oh, good.
You know, after having
I'm sitting there go, wow. Yeah, I'm gonna say I was the medical director I was the medical director for a state of Pennsylvania, right back in 1998. So it's been over a quarter of a century you were there, right?
Yes, I was going to say after 27 years of doing this all by myself, you know, they're trying to get me help. So assuming that's correct, I will get help. Otherwise, assuming it's not correct, I may be moving into my nursing home a little bit earlier.
Okay, great. So there's, you know, it is amazing because you've been there and did such a great job for 27 years and you're so matter of fact, but here's the latest problem du jour. And so we just love having you. So you frightened me there for a second. So that's cool. Well, good for you. Now, who's coming in from? The commissioner? Is it coming higher up in the mayor's office or where is it coming from?
The RFP?
Yeah.
I'm not sure the driving force. I know the previous commissioner for the longest time wanted more leadership among their medical directorship, realizing it's a big job. And so I think he was trying to just bring us up into the 21st century. And we sort of got dragged along kicking and screaming.
So our never, ever cynical Terry Valenzuela says, Crawford, it's a trap. Don't fall for it.
Well, no, thank you, Terry. I am Terry Jr. for a reason. Just throwing in another topic real quick. With FIFA coming in, some of you guys may remember the Amtrak crash in Philadelphia in 2015, where 8 people were killed and the police ended up transporting most of the patients. Right. And I throw this in addition to the longstanding practice of the police transporting shooting victims. With FIFA coming, we're actually now finally having a pretty serious conversation with the police about how best to to involve police and MCIs in such a way that will benefit patients without overwhelming hospitals and making sure patients get to the right place. So I think after, you know, decades of this practice, we're trying to add a little bit of reason to what both departments are doing. And so I'm looking forward to that progressing and actually leading to something pre-FIFA.
Yeah. Okay, got it.
That's all I got.
There's a lot of people that probably would love to talk to you, by the way. And maybe you wouldn't have the same issues, maybe. Okay, but like Keegan's on, for example. Unfortunately, we lost Clayton Kazan had to go off. But Keegan, any comments you want to react to that, or I want to establish a relationship with you and Crawford as well? Okay.
That's assuming I'm still employed.
Yeah, that's right. Go for the trap. But
hey, if you're unemployed, we'll bring you out here as a consultant.
Okay, cool.
Yeah.
But Keegan, anything to react to that, or any questions, or because you're learning all about this. This is a great thing, right, for you, right?
Yeah. No, we just had a site visit from the U.S. FIFA Dr. Osman. So, you know, not a lot of super big answers that came out of it that I can really share with y'all at this point, but yeah, it's still shaping up pretty well. And PD's been very good about wanting to work with us. They kind of silo a little, but I think they're realizing this is gonna have to be a very much joint effort.
Yeah. Okay. Got it. All right. Well, anybody else have any comments that are doing FIFA cities that are going to be involved here beyond that, or want to make a comment about it? Okay. Then let me then switch back to Dustin quickly, because not much has been coming out of Cincinnati lately. Anything to report besides what you said?
No, just what I said. We like to maintain our reputation of nothing exciting in Cincinnati.
Good. Okay. That's funny. Yeah. All right, let's go all the way out into the Pacific. Anything new happening out in Hawaii, Libby?
Yeah, our governor declared a state of emergency surrounding COVID. So anybody should be able to go to the pharmacies and get COVID vaccines, just same as how we did during COVID.
Yeah. Okay, good. And do they have the MNEX spike there, as far as you know?
I haven't checked yet, but yes, I'm definitely gonna check.
Everybody
I believe they do.
Yeah, everybody in my family's already got the MNEX spike, and so yeah, I think good plan. That's why I'm asking. So make sure you can do that. Thank you for tell the governor I said hi and thank you. Okay, I really appreciate it.
You know, on that note, the state of Florida went ahead and had its board of pharmacy meeting and did allow standing orders for the vaccines, which of course is much better than where we were before.
Okay. Good to know.
I did have a question for the group on the COVID vaccine. I went and got mine recently, and I asked the pharmacist because they didn't ask me about any of these preconditions that were placed on with the FDA. He said no. There was another group that he mentioned that actually came out and said no. Everyone can get it, and he said that's the one insurances will typically follow. And the name of the group or the acronym board escapes me, but I don't know if anyone else has run into that as well. And it's a good thing.
Yeah, it's a board of pharmacy. They're appointed by the governor. And currently, I think 8 out of the 9 members were appointed after the current governor's views on vaccines changed. Only one has the original views, but nonetheless, I think they made the best decision they could under current climate.
Yeah. All right. Hey, Eileen, just so you know, is that I came across a situation where someone I knew had taken Paxlovid and they had rebound. And then later they said that they couldn't get it for another 6 months because Medicare wouldn't pay for it. And it's like $1,200. So interesting enough. So just be aware of that. It's interesting to look into. I didn't know that there was such a regulation or when they put that in or if that's the case or not.
Yeah, that's very unfortunate. And it's, it varies with a bunch of things, but the bottom line is the evidence, and there's a new study again showing, no doubt about it, taking Paxlovid while you are symptomatic with COVID, if it's indicated at all, is going to reduce your long-term risk of long COVID and hospitalizations and everything bad. So it's a great drug, and I'm really sorry to hear about the insurance issues. That's quite unfortunate.
Yeah, we'll talk about that later. So, anyways, but just wanted you to be aware of it because I don't know if that was something in Texas or the store that we used or whatever, that kind of the people that were involved. All right, so let's jump over to Toronto, if you don't mind, Mike. Good to see you again. Anything new to report? Oh, let's go with Ken real quick before I go to Toronto. Ken, yes, go ahead.
I just a quick question for Eileen, if she knows, and I don't know if she knows. There was a new formulation similar to Paxlovid that was in the pipeline that I think was just a once a day and was a little easier to take. I don't know what it's called, but it worked the same way. I don't know if you know anything about that.
Yeah, actually, there's several protease inhibitors that are now available. In fact, if you like, I'll go ahead and send you an email about it because it's sort of a long conversation. But there's some really great ones in Asia, actually, as well. So I'll give you the details. But yeah, there's several.
Great, thanks, Eileen.
Paxlovid is just easy. Everybody knows what we're talking about.
Yeah.
Bye.
All right. And before I forget, Jim, obviously, if you remind me, I wanted to sort of communicate the article we wrote about the estrogen, and I'll have you just send it out to the group as a group mailing later.
Very good.
Just
Very good.
Remind me. Now let's see. There was trying to remember after Ken's. Oh, Ken. Here I want to tell you about. Ken wrote this incredible paper that probably stimulated 5 billion, reviews, so to speak, about giving a monoclonal antibody, at least for the alpha type of, of COVID, et cetera, and how it reversed the long COVID in these people within days, even if they'd had it for a week and a year and a half, 5 months or 8 months or 10 months, it worked kind of immediately. And it may have been just the one involved, but what's happened with that? Has that gone into any kind of a follow-up? Because the drug that was being used at that time, Regeneron, I think it was called, is no longer manufactured because it was under an EUA at the time and blah, 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 et cetera. And they weren't interested in re-upping it again. And then, so where are we on that? Because there's a lot of people out there suffering with long COVID.
Yeah, well, I have good news on that. I mean, for years I tried to get somebody to do a study on this because the Florida Department of Health doesn't normally do studies. And finally, I just like, we're gonna have to do the study ourselves. So we partnered with Nova Southeastern, Dr. Nancy Klimas, who helped us on that first paper. And we've got some additional funding from some not-for-profits and some about $500,000 of funding from the Department of Health. And we have a double-blind, randomized, placebo-controlled study with 100 participants going on right now using a monoclonal from AstraZeneca that covers all known variants all the way up to early Omicron. Because our theory is that it's chronic spike production that's causing you to feel sick, whether and have long COVID, whether it's some of these folks from messenger RNA vaccine injury that we hear about, which is really rare, or whether it's from the much more common long COVID you see from COVID itself. Our theory is that they've got ongoing spike production that's causing all these symptoms, and that's why it went away so quickly when we gave them monoclonals with Regeneron.
That's fascinating. That's it. That answers that question. Then that's interesting. And then, but there's been use of it like overseas, right? That weren't necessarily controlled trials of the same kind of drug or the same drug.
Yeah. I mean, you're gonna have to take this for the hearsay that it is, because I don't have any firsthand knowledge of this, but there is a physician over at, I believe it's Cambridge, who has been using the same exact monoclonal on long COVID patients in his practice. And supposedly he's 3 for 3. I haven't gotten any update for that, man. He's given it to 3 patients and 3 patients have recovered. So let's hope that turns out to be the case. We'll see.
Hope he comes back.
We'll have a definitive study soon.
And hopefully it comes back and has a Ken Shepke. We've done 100 patients now, and it happened and worked in every case, right?
We'll see. We've injected 30 patients so far, but it's blinded, so I'm not going to know the answer for a little bit.
Right, exactly right. Ken is like, I was Mr. RCT. I started the first ones at pre-hospital care years ago, and so working with Ken Shepke is great because he knows the right stuff. Like when we did the ketamine study, when it's 100% effective, I don't think you have to worry about, going out and doing RCT on that. So hopefully that'll be the same case here. We'll see if that guy comes through, but we'll see how. But 30 patients sounds good. There's probably a lot of patients, but is there a limit to what she has in terms of funding, number of people she can treat?
It's going to be 100 patients, and it'll be 50 get placebo, 50 get injection. But at the end of 6 months, it'll be a crossover. We did get FDA approvals for the 50 that get the placebo. They will be able, at the end of the 6 months, once it's unblinded, to get the drug. So all 100 can get the drug if they want.
Oh God, that's fantastic news then.
Yeah.
Oh, that's great. Okay, good. I like it because I have a high level of confidence here and all that on this. Okay, let me try once more with Chris Zuver. Are you around, Chris? Chris Zuver, are you there? And please respond. Can someone do a chest thump or something like that? Okay. Well, if not, then we'll just move on here. Okay, David, anything in Vancouver we should know about? I got to wrap up pretty soon, anyways, right? Okay. David, anything happened out of Vancouver?
Nothing specific. It's the same. I think I mentioned last week, as Mark Gautreaux said, volumes are up. We have certainly not a new issue, but hospital closures definitely make the operational logistics in terms of it does result in more interfacility transfers, which then relies on our 911 fleet, and so that's a problem that's an ongoing one that we're continuing to try to find solutions for, but otherwise no specific things going on here.
Okay, how's your weather been?
Weather is definitely the rainy Pacific Northwest. Fall weather has arrived.
I figure that's so, and it's getting dark by 3 o'clock in the afternoon. No, not quite 3, but at least it's getting dark by about 5 or something like that, right? At this point in time of year, it's interesting. I actually remember going to work in December, and it was by 4 o'clock. It was raining and dark, etc. When I was in Seattle, and you guys are a little further north, so
yeah.
Okay.
Nice.
Let's jump over to Toronto since we're up in Canada. Okay, so Mike, anything to report out of there?
Well, nothing exciting in terms of incidents, but something very exciting in terms of what I learned in visiting my U.S. counterparts, which is rip off and duplicate. We're in the process of setting up a Canadian pre-hospital blood transfusion coalition, and we just had our first little meeting. And I'm grateful to the introductions that were made, and to Peter Antevi, who got people thinking about it, and then Chief Eric Bank, who participated in our first little meeting. the other thing I learned from Peter is ChatGPT does some amazing things, and overlaying a map of the greater Toronto area with 7 million people with the distance trauma centers, about 40% of our population cannot access a trauma center in a timely manner. So many of you on this call, Matt Levy, Don Jenkins, too many people to name, have been involved with getting pre-hospital blood and pre-hospital low titer type O blood. I may at some point be reaching out to you just for, to discuss your experience in overcoming state and institutional and blood bank barriers. On the one side, we have like a national blood donation service, and on the other side, it also means that there's a lot of institutional resistance to change. But we'll be working on it, and we started today.
All right, congratulations then. That's fantastic. And thanks to the other folks that you mentioned for helping out, Eric in particular. So I was going to say, is Eric on top of this so he could follow that? And there he is. He's there, so that's good. All right, Glenn, anything report out of New York besides the UN General Assembly, or is that just all consuming and that's all the report on that you had?
Yeah, no, that kept us very busy this week. Luckily, officially it's done today, besides this couple small meetings. So we are good back in New York.
All right. And then, okay, thank you very much. I really do appreciate it then. That was that. And Shay, anything out of Denver that we should know about?
No, kind of same business as usual, working on our response time overhaul for the system. That'll be big, and hopefully we'll be able to present on that. I've had some help from people on this call. It's been great. So more to come, but that's still in process.
Hey, what roadway would you take, like 25 if you had to get down to Colorado Springs?
Yes, but do it either overnight or really early because the traffic is terrible during rush hour.
Good to know. So let's go right now if we can.
Let's do it.
Let's see what Stein has to say. Stein, anything to report out Colorado Springs?
Nope, nothing new for us out here.
Okay, good. Thanks a lot. Good to see you. And thanks for your help. We need to get together, by the way, and update the website and get the word out about the June 1st meeting, or I guess for the public, about the Gathering of Eagles being on June 4th and 5th next year down there at the convention center in Broward. All right. Hey, Vicente, anything to report out of Iceland? Anything else, any nuances there or anything else that you can recite? And did you get the information you needed about the CME? That's the most important one, I guess, right?
Yes, thank you very much. So the winter is coming, yellow warning today. So not a good day for driving in Iceland today.
Yeah.
We're working on renewing our clinical guidelines, pedaling a lot in that, and not much ongoing. Madrid down in the south of Spain, excited about Formula One 2026. So it's going to be big event. First time in a very long time that there's a Formula One coming back to Spain.
Hey, a quick question for you is when does it, let's say if you're December 21st, how many hours of light do you have at that time in Reykjavik?
From 10 a.m. to 4. But this is the technical truth, but it might be very, very cloudy. The weather is bad.
Yeah. Right,
so
right.
We get a reduced light here,
Yeah, exactly right. So, okay. Well, listen, thank you so much then for your comments, and great to have you on. I'll try Chris Zuber once more time. Chris, are you around by any chance? If not, then let's see, who else did we have here? Let's see, Glenn, Holly, anything that we should know about from DC, Washington, DC?
Dr. Levy has been an exceptional partner to work with. I know he's not on the call anymore. We now have an open IRB through Hopkins, so you're going to start seeing a publishing machine out of DC on our data. We're getting ready to hit our 400th unit, and it was perfect timing. I've been off for a couple of weeks and have been able to start working on a couple of papers about what we're doing and a bunch of the trauma data that's going to come out.
Okay, fantastic. That well, I got it's right below your name is Josh Hartman. We hadn't seen you for a while. Josh, anything to report from your end besides you have some conference or something coming up in a month or so? You there, Josh Hartman? Okay, so then let's move on. Rob, well, while you're there, Rob Glatter, anything to report from your end from Medscape?
Nothing new on my end, Paul. Just waiting to, actually, I did hear back, interestingly, from Jeff's compadre, Matt Shaw, on that paper we had talked about the other day, but no movement there.
Yeah.
There was also an issue of a locally acquired case of chikungunya. I don't know if Eileen's still on the call. We had
Yeah, she's
texted
here.
about that a little bit. There's
Where
no
was-
confirmation. I don't.
Where was it?
On Long Island. It's not clear, and a lot of the molecular testing isn't back yet. But
Okay.
this will be interesting. You know, obviously it's all travel driven, and that's how these cases are acquired. We know this, but
You must live in Manhattan, right? Because
Yeah.
you said Long Island, not Long Island, right?
Long Island.
So, all right. Well, Eileen, anything you report on that, and then I'll come to you, Chris, in a second.
I'll talk about chikungunya in just a second. Just to answer Libby, I sent the protease stuff to everybody, not just to Ken. Okay, so chikungunya, yeah, love that disease. Really fascinating, horrible thing to get.
I love that disease.
Well, it's an arboviral.
Is that a foul remark?
No, because the chikungunya has nothing to do with chickens. It has to do with that sensation of being bent over, which is where the word comes from, which is a word from Tanzania. Yeah. So anyway, it's we see cases autochthonous in the U.S. of chikungunya every year. It'll contain, somebody will bring it in their blood, and it'll affect local Aedes mosquitoes because it infects Aedes aegypti and Aedes albopictus mosquitoes, which we have in abundance. What we do then is we target the particular area where there's autochthonous cases, because thank goodness Aedes mosquitoes don't travel more than 400 or 500 meters from where they're born.
Right. So anyway, so interesting, but thanks for bringing that up again and give me an opportunity to tell a bad pun, etc. as usual. And thanks for aiding me on that one. So I appreciate it. So let's see now. Let's move on to Chris Zuber out of Orlando. Anything to report out of Orlando or Orange County? Anything we need to know about, Chris? And then I want to mention something to you personally after that. So go ahead.
Hey, Paul. Let's see. We're trying to get all switched over to Pulsera, which is becoming. It's a process, but we're working our way there for pretty much everything. We're testing it right now. It seems to be going pretty well. Protocol reviews, our resource center we finally got one here.
Yes.
We're hopefully going to have some data soon from our ECPR protocol. We have a couple of good cases we're getting ready to celebrate with our crews. And we're working on some you may not believe this. Most folks who, when they come down to one of our parks, don't want to go to the hospital when they call 911.
Kidding.
we're working on trying to do some innovative algorithms for care at one of the parks. So we'll see how that kind of plays out as we kind of work through it.
Okay,
That's the big stuff.
Hey, I was originally going to be putting you on the program for a meeting we were having in Brevard. I think you remember that, and I just couldn't get back to it. And I think I'm kind of overboarded now because I got David Purse on with us. But if you're still welcome if you want to come over and just be with us and be on panels and join us. I'd really appreciate it. It's on October 10th over in in Brevard at the Posey Center there. I'll give you more information if you're available. I just wanted to tell you you're always invited is all I'm saying. Okay.
I appreciate it. Yeah, send me the stuff for the 10th, and I will I'll if not, maybe I can pop over and just and visit and chime in when appropriate.
At the very least, we can hang out together, so which is good. That sounds really great. Okay, anybody else? I think it is time for I've got to return to my bride of 35 years, and I was going to say, welcome back, my friends, to the show that never ends here. And so we'll come back. But anybody else have any final words, any last words, or anything else you want to report before we get together next week? So next week, today is so next week is the 3rd. Right, October 3rd. Yeah, I'm going to actually be in St. Louis. So I'll be reporting from my hotel room in St. Louis. I'm at a Priority One conference with our good friend, Dr. Gilmore there. So I'll be reporting from there at that time. So anybody else have anything else to comment about? If not, I'm actually going to try to bring, I'm sorry she couldn't make it this week. Maybe I'll bring Jane back and we can maybe talk to her about some of those things like Jim Augustine brought up, like about progesterone and some of the other things in testosterone, because she looked at all those things as well. So it'd be kind of good to get some more follow-up on that, because I think it's a great topic as far as I'm concerned. So especially for us resuscitating people. Okay, with that, if I hear nothing else, then I'm going to go. So Tomas and Vicente, you guys all set on the CME thing, or you still need some help?
No, thank you. I have done it. So it's all good. Thank you very much.
Okay,
All
good.
good
Yeah,
here. Thank you very much.
we could claim a 1.5 here, yeah, for our show here, or unless I tell you otherwise. Okay, so it sounds good then. And thank you very much. So it's Thomas. What's happening? That they're requiring you to get CME over there where you didn't have to do it in the UK. Is that right?
Well, in the UK, it was much more lax, but the UAE is obviously much more like the American system. So I have to collect all the badges.
Okay, got it. All right, good. Well, listen, I'm glad we got a system for you here, and then if you can, try to remember some of the topics, because do they have any specific things they need from you? Meaning that, like, for example, in Florida, I have to do a CME on medical errors. Okay, that has to be actually an approved course for 2 hours and all that. And is there any other requirements, or just general CME that you have to do?
It's just general CME, thankfully. Yeah.
Oh, good. Then this is going to be very helpful. If you're on every week with us, you can pick up easily an hour every week. What are you going to have to do? About 40 a year? Most places require 40 to 50. What about you? Yeah. Okay, good. Well, listen, thanks a lot. Thanks for your job down there. And I'm hoping to see you in Chicago. At least, I'll try to stop by. We'll see how it goes, because I won't be presenting anything this year. All right. So good. All right, everybody. Listen, everyone have a great weekend, and welcome to fall. Now that we've had the summer, the what do you call autumnal equinox last week, or this couple days ago, and have a great weekend. Enjoy yourselves, and just can't wait to see you back next week. Take care. Bye-bye.
Thank you. Bye.
Thanks again.
Thank you.
Thank you.
Thanks.